Now, the next thing I'd like to talk about is seronegative spondyloarthritis. So this differs from rheumatoid. The pattern of involvement is different. So spinal involvement is very typical, either the lumbar thoracic spine or the sacroiliac joints. But you can get large synovial joints involved. I'm not going to talk too much about psoriatic arthritis. That can affect the small joints also as well. I'm mainly going to focus on ankylosing spondylitis. It's an inflammatory condition, so in this disease you get an acute phase response, but the rheumatoid and CCP antibodies are negative. That's why it's called seronegative. On radiographs you see sacroiliitis and syndesmophytes, and I think you can see on this x-ray syndesmophytes. These are bridging areas of bone between the vertebrae, and often seroneg can coexist with things like psoriasis, with inflammatory bowel disease, ulcerative colitis, so there are often other coexisting diseases. I have shown a picture of sacroiliitis. I've just increased that for you so that you can see it a bit better. So this patient with Ank-Spond, sacroiliac joint has become fused, and I think you can see a bit of sclerosis where the sacroiliac joint was. Now, management of ankylosing spondylitis, again, like all diseases, early diagnosis is important so that you can treat the patient properly. Physiotherapy and exercise is very critical in this condition. We do use NSAIDs and analgesics as first line, and if the patients have peripheral joint disease, like say a knee, an ankle, then DMARDs like methotrexate or solazopyrene are often used. But the only thing that works for spinal disease is anti-TNF therapy, and it can make a huge difference to patients that have this condition if they don't respond well. And I'm just showing data from a slide from a trial in the Lancet. This is the first trial to demonstrate efficacy. Infliximab versus placebo, and this is what's called the BASDAI score. It's a score of activity showing a tremendous increase with the anti-TNF agent versus placebo. So again, with Ank-Spond, a lot of advances in treatment with the biologics. Okay, here's another seronegative clinical quiz. 25-year-old man is a tire fitter who has back pain, which is worse in the morning. His symptoms are helped by diclofenac, and you suspect he may have ankylosing spondylitis. The reason you suspect that is early morning stiffness is quite a characteristic feature. Obviously, if you're a tire fitter, you might hurt your back, but if you're stiff in the morning, that's a suspicion of inflammatory disease. So, what investigations might help? And maybe more than one is positive here. An X-ray of the pelvis, X-ray of the hands, rheumatoid factor, ESR-CRP, or ANA. X-ray of the pelvis, who says yes for that? Quite a few. Hand X-ray, one person. Rheumatoid factor, no people. ESR and CRP, a lot of people. Anti-nuclear factor, no. 2, 3. The answers are X-ray of the pelvis, well done. You're obviously taught very well at this college, or you're very good students, or both. That may demonstrate sacroiliitis, a fusion of the sacroiliac joints, and ESR, CRP also may be helpful. You may have a high ESR if there's inflammatory activity going on. So we're doing good so far. So we move now on to crystal-induced arthritis. By that I mean gout and pseudogout. Now, the classic feature of crystal-induced arthritis is it's a sudden onset. The joint becomes acutely swollen and painful. It's usually a single joint, but not always a single joint. And in fact, often septic arthritis enters into the differential diagnosis. Once again, we've got inflammation, so there's usually an acute phase response. But radiographs may give a clue. You may see chondrocalcinosis, which is deposition of calcium in the cartilage. That's a patient with chondrocalcinosis. You may see erosions in gout, and in gout they're punched out erosions. In rheumatoid there's a lot of periarticular osteoporosis. You don't see that in gout. And you may see tophi. Here's a patient of mine with intractable gout, with the most terrible tophi. And this can be a very disabling disease. There have been a lot of new developments in the pathogenesis of gout. We used to think it was all eating too much rich food and boozing too much. But in recent years, we realized the importance of genetics in gout. And in fact, there are 5 genes now have been identified which predispose to gout. This gene, SLC2A9, is the most important. And what it does is it transports urate in the kidney. And if there's a certain variation in then, it means you reclaim more urate and you're predisposed to gout. So not to say environmental factors aren't important. Obviously there are. Alcohol excess, dehydration, injury can trigger an attack. Finally, one thing we haven't realized until recently, that fructose actually can predispose to the disease because it apparently competes for urate. Oh no, it's metabolized to urate within the body. So that's gout. There have been some new development in treatments. Allopurinol is obviously the classic treatment for gout, but this new drug has become available, febuxostat, that inhibits xanthine oxidase, and it seems to be superior to allopurinol. At the moment we use it second line. And also there has been experimentation with uricase, which actually will degrade uric crystals, and the early indications of that, it's not yet licensed, is it very effective for tophaceous gout. So finally, the last condition I'd briefly like to cover is osteoarthritis. Now here the joints are swollen, but it's a bony swelling. And if you look in the hands, you can often see these are Heberden's and Bouchard's nodes in osteoarthritis. Unlike the other diseases that I've talked about, there's no acute phase response. The ESR and CRP are normal usually. And synovitis isn't usually present, or if present, it's very mild. And you see typical features in radiographs of osteophytes. These are osteophytes in the hands here. In fact, that's why you get the swelling. These are osteophytes you're feeling if you see a patient's hands with osteo. You get joint space narrowing seen here in the knee and here in the hip. And typically there aren't any erosions, unlike rheumatoid. Where does OA affect? Well, many joints. Clinically, the most important sites are the hips and the knees, but also first MTP. Obviously, it can affect the hands, Bouchard's nodes and Heberden's nodes, also the AC joint and the spine. In the spine, we call it spondylosis, but it's osteoarthritis, although it's called lumbar spondylosis. And in the cervical spine, it's also called spondylosis. Now, what about management of osteoarthritis? Well, here, unfortunately, we don't have any disease-modifying drugs. We have to control symptoms. We do that with NSAIDs, analgesics, sometimes things like amitriptyline. Education is very important, what they can expect for the treatment. And obviously surgery is an option in patients with advanced disease. Intra-articular treatment can help, intra-articular steroids or hyaluronic acid. Although steroids we use a bit, hyaluronic acid isn't used so much in the UK. It's quite expensive and only really has a weak effect. If I can reflect on how things have changed since I graduated, this is the pyramid for treatment: analgesics, NSAIDs, amitriptyline, opiates, and surgery. Unfortunately, 25 plus years later, the only thing new we have is topical NSAIDs. So for any young doctors out there or students, you want to go into a specialty, you want to make a difference in research, osteoarthritis, that would be a good thing to go into. Really, it's an area where we need a lot more research, need to find out a lot more about it so that we can get better treatments for our patients in the future. Okay, this is the last clinical quiz. You'll be glad to know you've all done fantastically well so far. So here's a woman, 75, pain in both knees, worse going up and down the stairs. Hematology and biochemistry are normal. ESR is 11, but she's got a positive rheumatoid factor. So, what's the most likely diagnosis? Rheumatoid, gout, OA, pseudogout, or scleroderma? Hands up for rheumatoid. 1. Gout? That the same person that said gout? Scleroderma? No. The answer, of course, is OA. Well done. And actually, I shouldn't have shown this x-ray because I gave it away, but you can see subchondral stenosis, connective tissue disease. These are a wide group of diseases. And unfortunately, the clinical features are often non-specific. Usually see an acute phase response, but not always. And there are some diagnostic markers, for example, ANA or anti-double-stranded DNA for lupus, anti-SLC70 for scleroderma, muscle enzymes for dermatomyositis, ANCA for vasculitis. I just thought I'd show you some pictures here. Of course, this is the typical butterfly rash of lupus. It's a patient of mine with lupus, cerebral lupus. She presented with paraplegia. What you're looking at here is inflammatory areas in the spinal cord. These are Gautron's papules in dermatomyositis and digital infarcts in scleroderma. So very wide manifestation. And you can see that if you look at the ACR criteria for lupus. There's a bewildering number of symptoms or signs that you can get. If you have more than 4 of these, that would be diagnostic or very suggestive of lupus. So what do we do with this condition now? Well, things have changed again over the years. I think we're recognizing lupus is occurring much more commonly in a milder form. So patients sometimes just have joint problems, which you can manage symptomatically with NSAIDs. Antimalarials, hydroxychloroquine for skin and joint disease. Obviously, if you've got lupus anticoagulant, then anticoagulants can help there. Some features like hemolytic anemia, thrombocytopenia can be managed with steroids. But if you have CNS lupus or renal lupus, then that's an indication for high-dose steroids and cytotoxics. So that's it. I mean, I've only given you a taste of a few of the fascinating aspects of rheumatology. It's a fascinating specialty. I hope I've got over the idea that there have been advances in many areas in treatment and understanding, although much further research is needed. And of course, I'm looking at it because I genuinely think it is a very good book, and will give certainly all the essential information from rheumatology. So, thank you very much. I'd like to thank Elsevier India and the UK for allowing Nikki and I to sponsoring our trip here. I'd like you and your medical college for inviting us here. It's been a pleasure. It's been a delight to come along and meet you all this afternoon, and the audience for listening and getting the questions so correct. Thank you.